All right, so this is inflammations now. So this is an infection affecting the heart. So how did this get here? So let's review fundamentals of nursing. We have what are the chain of infection?
Professor, what chapter was this again?
We're still in 35.
Oh.
All right, so let's review. What are the chain of infection?
You have to have a medium for the bacteria to grow.
No, I mean, what are the chains of infection?
Oh, I'm sorry. The change?
Chain, you know the 6 chains of infection?
Oh, well, yeah, I kind of said one of them. I mean, like having a place for the bacteria to grow.
Okay, so that's the reservoir. So
Yeah.
the first one is the organism, right?
Mhm.
So you need an organism, and then we need a reservoir, and then we need a portal of
exit.
yeah, and for that thing, well, entry first, because it's a there's a reservoir, and then entry, it enters the body somehow, and then after it enters, that would mean there's a host, right? There has to be a susceptible host, and then finally there's a portal of exit, and then the cycle goes over again. So let's start with the organism. So what is the causative organism here? So the frequent causes are strep. So this is the same strep causing strep, and also Staph aureus. Staph aureus is common. You'll find it mostly anywhere, every surface, mostly. That's why we need to wash hands. What do you call that? The ability of dirt and stuff to stick, which is what's surface tension. Okay. Soap lowers surface tension.
Breaking out pretty bad.
How about now?
That's better.
Okay. All right. So I was saying our causative organism here, most common are Streptococcus and Staph aureus. So this is your causative organism. Then we need the portal of entry. So we have portal of entry would be the bloodstream. So these are the possible ports of entry here. The mouth is number 1. Another is through the skin. So you have a skin lesion, a wound, for instance, an infected wound on this, either on the skin, in the genitourinary tract. So it could be from a complicated UTI, GI also, or systemic infection such as straight through the bloodstream via surgery or via IV line placement. Now, this IV line placement can be a peripheral or a central line. So those are our portals of entry. Now, therefore, let's look at the susceptible hosts. So who are likely to get endocarditis?
IV drug users.
All right, so that is the IV line, not only IV line placement, but also IV drug users, right? So that's how the infection goes. Now, why the endocardium though? Why can't the infection just stay somewhere else and not inside the heart? Well, if you were a streptococcus or a staph organism, what do you need to survive, to thrive, to have children and grandchildren? What does a bacterium need to live?
Oxygen.
right? Just like you and me, we need oxygen, we need glucose, right? Now, where would be the best part of the body that has the best oxygen, the best sugar? Where will you find that? The freshest oxygen, the best glucose.
Would it be the heart?
All right, which part of the heart? If you were to choose, where would you go?
I'm gonna take a shot in the dark and say it's the endocardium.
Right, but which side of the heart would you go on?
The
Left.
left ventricle.
Right, so the left side would be the best because the right side doesn't have much oxygen. Those are all deoxygenated blood. The freshest oxygen is on the left side. So that's why the most frequently affected part here is the mitral valve. The organism tends to form or develop vegetations. So vegetations are they're like plaque, but they're not they're not stable plaques. Meaning, these are areas of where white blood cells start fighting the organism, and then there's also platelets and fibrin that adhere. So this is what causes a vegetation in the mitral valve. Plus, it's a very conducive area because it's not smooth; it's very rough. If you imagine the connective tissues around the valves, so it's a perfect area for you to grow. And besides, they cannot stay there peacefully because it's not really a peaceful area. The valves constantly open and close, so it's very violent in there. So the only way they can stick somewhere is to form vegetations, and then these vegetations, of course, stick to the valve, and they grow there. Now, for the same reason also, because it's not a peaceful area, it's so chaotic in there. So what will happen is there will be pieces of the vegetation that will break off and become emboli. So this is one of the problems that will be cause, you can call them complications, are embolization. So these vegetative lesions can become emboli. The problem is these are not blood clots. So your body, you can't treat this with anticoagulants because they're not blood clots. Okay, they are vegetative emboli. So they're solid pieces of foreign material. So we'll just wait until the body, your white blood cells eat them up, by phagocytosis. Until then, though, so that this will explain some of the symptoms that will be present. So here are how we can tell that the patient has endocarditis. So the patient is not well; they have an infection, systemic infection at that. So first symptoms are non-specific. So anyone who's sick. So you come into the ER, you look very sick. You have fever, you don't feel good. You have anorexia, weight loss. Interestingly, because there is vegetations forming in the valve, they tend to damage the valve. So if you didn't have a murmur before, now you do. Or if you had a murmur before, it will change. Okay, so indicating further damage to an already damaged valve. Either way, it will produce a murmur, either a new murmur if you didn't have one before, or an existing murmur will change. Now take note that this is a permanent damage to the valve. So therefore, we already discussed valve disorders last week. This is depending on the extent and severity of the valve damage, which the doctor will need to do an echo in order to look at the extent of the damage. He'll decide whether or not it needs to be repaired or replaced. Because the patient develops valve problems, so therefore there will be heart failure at the same time. And as I already mentioned, some of the emboli can break off from the vegetative lesions, and then they'll end up somewhere. Where do they end up? Well, they'll go to either the hands and soles of the feet or go to some GI organs. Good thing here is they're not that big to usually cause a stroke or a heart attack or a PE. They're not that big. Rarely do they cause an MI, a stroke, or a heart attack or a PE. Sorry. But these lesions and maculae are only found in endocarditis. No other disorder has these. So if they appear, doctor will make a tentative diagnosis that this could be endocarditis. The only way we know for sure is to do a blood culture. So we draw a blood culture, and that will of course grow either streptococcus or staph aureus, and then to see whether or not there is cardiac damage, the other test we will do is an echo. But the the diagnostic test to confirm is to do a blood culture. And we'll do the same to evaluate whether or not the patient's treatment worked is to do another blood culture. So as already mentioned, heart failure is the most common complication because it does damage a valve. So we won't repeat heart failure symptoms again. It really depends on which valve is affected. Like I said, bacteria are smart. They'll go for the best, and the best, of course, is the mitral valve because it happens to be on the left side. I'm not saying that the pulmonic, aortic, or tricuspid valves won't be affected. They will. However, like I said, you know, if you're smart, you'd go for the best place, which is usually the mitral valve. So these are the areas where the embolization will occur. So it can block circulation. They'll end up in the spleen, kidneys, GI tract, the brain sometimes, and then the extremities as well. Read the rest, they're already on the chart. As already mentioned, so a blood culture, a positive blood culture will be used to confirm the disorder. And then we need an echo. The best echo here is not a two-dimensional echo, but a transesophageal. So this is done like an endoscopy. So instead of just putting the probe over your chest wall, we'll put the probe down your throat, inside the esophagus, so we can get a closer view of the heart, okay, internally. So this will provide the best picture of your heart valves. So treatment, because it's an infection, of course, the patient will receive antibiotics. On top of it though, remember the patient develops heart failure because of the damage. So on top of that, we will do the doables. We'll treat this patient with diuretics, oxygen, beta blockers, etc. So you treat the heart failure, and at the same time, you also treat the infection. Remember, the heart failure will not go away after this, because remember, heart failure is permanent. Even if you repair or replace the valve, the patient is in heart failure here forever. So how long is the antibiotic therapy? It's 4 to 6 weeks. Now, what did we learn in chapter 13? What is the venous access device here if we're giving long-term antibiotics? This is 4 to 6 weeks. So can we use the peripheral line here? What will be your venous access?
Central one?
So it'll be a central line, or most commonly it'll be a PICC line. So what did we learn again? What was one of the portals of entry? It was also is central line one of the portals of entry?
Yeah.
Yes.
So what say here? So this patient could have gotten disease via a central line. So, and we're using another line here in order to use to administer antibiotics. So therefore, put those two together. What is your priority for this patient?
Keeping sterility when.
Very good. So your septic technique here when you in the central line and also doing dressing changes, because remember this is 4 to 6 weeks. In most settings, people don't stay in the hospital for 4 to 6 weeks because you're only receiving antibiotics. You're fine otherwise. You're stable. So patients usually are sent home and or to a rehab facility if the home is not conducive. So let's say the patient lives in a trailer park, for instance. Know that it's a tiny house, um, not the best environment for keeping a central line clean. So they may be put in a rehab facility, short-term rehab for 4 to 6 weeks. Another is, except in city hospitals though, I don't understand where they're not sending people home. I've seen patients stay in the hospital for the entire 6 weeks. But, you know, they're only there for antibiotics, so there's really no need to keep them inpatient. So the city is spending all of our tax money on this therapy, which could be, you can save more money if you take them out of the hospital. But that's just.
Excuse me, Professor. I just have a quick question. How do they know that it was that they came in? Like, how do they know that the PICC line didn't cause it? That they know that they came in with the disease already or something like that?
Well, it's easy. I mean, if the patient didn't have one before, then.
It's just as simple as that.
Right.
Okay.
Okay.
Professor, can you mute everybody? I don't know. I kind of hear back.
No, that's me. I'm sorry. It's my daughter.
Oh, sorry.
Sorry. It's out for now. So with regards to the heart failure, so the patient needs adequate rest, balance with exercise, then continue to monitor and treat for heart failure. Surgery-wise, this would be, of course, we already discussed valve repair or valve replacement. Excuse me. All right. So after this, remember that one of the portals of entry is the mouth, right? So patient needs to know to be instructed on proper oral hygiene. We don't want this happening again. And remember what we did in valve disorders. So this patient now has a valve damage. So therefore, will they need antibiotic prophylaxis before oral or dental procedures? Yeah?
Yes.
All right, yeah, man. Look at the action alert, right? So same thing. So it goes round and round. So you go from this to this. So it's the same prophylaxis, the same treatment, the same teachings. Right? Any question on endocarditis? That's it. So this is infection affecting the innermost lining of the heart. Now let's go to pericarditis. So this is now inflammation or infection of the outermost line. So every moving part of our body has a sac. The testicles are constantly moving, so they have a sac. And inside that sac, there is a liquid case for lubrication. Our joints are constantly moving, so they have a synovial sac with fluid in there. We have synovial fluid. The lungs are constantly moving, so we have the pleura surrounding the lungs to protect it from friction. So we have some lubricant there also, 5 to 10 mLs. And then we have the peritoneum enclosing the GI organs because our GI tract is also constantly moving. So, and then the heart also is not any different. So the heart is constantly moving 60 to 100 times a minute, 365 days a year. So it needs lubrication. So we have a pericardium doing that. Now, how does the pericardium get infected or inflamed? So these are our causes. So again, this is an infection. So remember the the chain of infection again. So we have positive organisms. However, it's not always infectious. There are other causes of pericarditis not related to an infection. One is called post-MI or Dressler syndrome. The difference between the two is the period. Pericarditis, acute pericarditis can develop right after an MI, meaning usually within 24 to 48 hours. So this is one of the complications of a heart attack. The dead tissue here, the dead myocardium, of course will cause inflammation because parts of your heart died. So therefore, as the pericardium comes in contact with that dead section, it will cause inflammation. So we call that acute pericarditis. If the pericarditis develops up to 2 weeks or more or longer after an MI, that is not called acute pericarditis anymore. That's now called Dressler syndrome. But basically, it's the same. The only difference is when did it occur. So again, first 24 to 48 hours, it's called acute pericarditis. If it's later, weeks later after the MI, it's called Dressler syndrome. Post-pericarditis syndrome is after somebody undergoes open heart surgery. We open the pericardium surgically, so that's a inflammation resulting from the trauma to the surgical incision to the pericardium. And then finally, it's also caused by lupus. So the systemic connective tissue disease referred to here is lupus. Lupus affects all connective tissues. So all the sacs I mentioned earlier are all connective tissues. Okay, so the peritoneum, pericardium, the pleura, even the meninges, okay, surrounding your brain. Those are connective tissues. So we have blood is a connective tissue, skin is a connective tissue. What else? Joints. Okay? We have connective tissue everywhere. There's no organ in the body that doesn't have connective tissue, because otherwise there's nothing holding us together. We are not testing chronic pericarditis, only acute. Okay, so you can skip the chronic part. So what are the patient's signs and symptoms? So remember, this is now the sac surrounding the heart. So for the ladies here, I'll use you as an example. When you party with new high heels, okay, you just bought your heels today and then you party, go dancing on the weekend, you get on the ledge and then just, get wasted. What do you develop on your heels the next day?
Blisters.
All right. So imagine that same thing happening, although that's not going to stop you, right? Even if you have blisters on your heels, it's not going to stop you from dancing.
No.
Away, right? So you'll keep going, even if your feet, your ankles are swollen already, like your feet look like bread, already, like you're baking bread in your ankles already. You keep going, right? So same thing here also in pericarditis. Can the heart stop beating because the sac around it is already inflamed?
No.
No. So this will account for the pain. So the patient now, because imagine the heart continues to beat and rub against an already inflamed sac around it. So of course that will cause fluid to accumulate. There will be a blister formation there. There will also be extreme pain. So the number one complaint is a pericardial friction rub. So this is a sharp, scratchy pain. You can also hear it, and then the patient feels it, okay, as the inflamed pericardium rubs against the heart. Okay, so that will be very painful. So what exacerbates this is if your patient's lying supine, when you're lying down flat, but you can relieve it by sitting the patient up and have them lean forward. So that will help relieve the pain. It won't eliminate the pain, it will just relieve it somehow. We'll have to give them pain medication for that. So we'll get to that under interventions. Others are because there is inflammation here, so blood tests will show. I forgot to mention these. This will also be present in endocarditis. So what are those two inflammatory markers again? Whenever you have an infection, these increase besides your WBC count.
Yeah, it increases WBC.
Right. What are the other two that are markers for inflammation? It's also present in rheumatoid arthritis, in lupus.
ST elevation.
No, that's for the those are in your ECG. So it's not written here, but from last semester, from you talked about these. Whenever you have a patient with an infection, what are the other markers that indicate inflammation? Because remember, inflammation comes first before infection. Remember ESR and CRP? No? Okay, anyway, ESR is erythrocyte sedimentation rate, and CRP is C-reactive protein. These are two inflammatory markers, meaning whenever you have an infection or a severe inflammation, these two will be increased.
Professor, what was the second marker?
CRP, C-reactive protein. So these are used also to evaluate. So remember when we were medicating the patient with endocarditis? So every week, we will be monitoring their blood work. Every week, we will draw blood for ESR, CRP, and WBC also to see is our antibiotic working. So we expect these numbers to be dropping. And at the end of the antibiotic infusions, after the 6 weeks is over, we draw blood cultures again and it should be negative. Okay? So same thing here. So if the cause of the pericarditis is an infection, then of course the white blood cell count will be high, and then we will treat it with antibiotics, antiviral, whatever the cause is. So if it's caused by lupus, then we treat the exacerbation of the lupus. Lupus has no cure, so all you can do is just keep the patient in remission. All right, so we treat the cause here, and then of course we provide supportive treatment because the patient is in pain. So here are the diagnostic criteria for pericarditis. So there is the chest pain, then you hear the pericardial friction rub, and those EKG changes, and then there will be this will be your blister. Okay, so this is now liquid accumulation inside the pericardium. The amount of the fluid in there will determine whether or not it needs to be drained. If it's pericardial effusion of more than 50 ml, that needs to be drained already because that's a lot of fluid around the heart sac. All right. So let's go now to interventions. So for pain, we give the patient NSAIDs. Patients do not respond to opioids. Okay? This type of pain is more inflammatory in nature, so the best relief will come from NSAID. So this would be ibuprofen, Aleve. If the patient has lupus, then it will be the patient will be given steroids. However, if the patient's pericarditis is from bacterial infection, no steroids are indicated. Right? That won't be good because that will suppress your immune system. Not good if the cause is infectious. And we already know about the positioning. In some cases, the patient will also be given colchicine. For some reason, this will also prevent the recurrence of pericarditis. We also won't do chronic pericarditis, just like in endocarditis, so we're only talking about acute pericarditis. Now, as far as the pericardial effusion, it's good. Well, it's better if it stays as an infusion, However, this fluid accumulation can increase, which is now called cardiac tamponade. So to give you a picture, all right. So why does the patient have these symptoms here? So let's explain briefly. So say this is your heart, and this is your superior and inferior vena cava, and this is your lungs, and this is now the pericardium. Okay, so it's supposed to be very little fluid in there. Now imagine if this will now fill with more than 50 ml of blood. So it will now look like this. So all this here will be filled with fluid or even blood. Now I'm only drawing this two-dimensional figure. Now imagine this is three-dimensional. So that means I'm only drawing around this heart on the side. Remember, the sac is surrounding the entire heart. So on the front, back, and sides of this heart are all fluid as well. So imagine the pressure accumulating around the heart now. And then here comes the lungs. So when we breathe, let me illustrate the pressure. So when you take a breath, it'll be like this. So let's say this is zero pressure. Then when you take a breath, you go like this, right? And then take another breath. So therefore, this is called peak inspiratory pressure. Peak inspiratory pressure. So this is when your lungs are fully inflated. Now imagine what's happening to the heart during peak inspiratory pressure. That means the lungs are filled to capacity. So there's increased pressure here. What's it doing to the mediastinum? So this is the mediastinum right here. This is where your heart lives. So during peak inspiratory pressure, what's it doing? What are these two lungs doing to the heart? Because they share the same thorax.
Contract.
So these two guys here, number 1 and number 2 lungs, during peak inspiratory pressure, when you at the peak of your inspiration, what are they doing to the heart?
They compress.
More pressure.
Right.
Squeeze it.
Yeah, that's fine though, because this is only, I don't know, 0.2 seconds maybe at the peak of your inhalation or inspiration. So that's fine. It's going to last 0.2 seconds. However, during that short period there, what's happening to the venous channel? Because you're squeezing the heart. So what happens to the amount of blood entering the heart from the upper and
Decreasing.
all right, it decreases it. Plus, meanwhile, you have all this fluid. Are they helping or are they preventing the heart from doing its job?
Preventing.
It's not helping, right? It's making the job extremely difficult. So therefore, if you listen to this patient's lungs, let's go back to your textbook. So now, because you're squeezing the superior vena cava at the peak of inspiration or inhalation, will there be jugular vein distension? Because can blood from the head drain normally back into the heart? If you have all that fluid around the inside the pericardium, and you have also the lungs squeezing it every so often, 12 to 20 times a minute, what happens to venous return from the head?
It's gonna decrease.
Right, so therefore proof of that, it will be jugular vein distension. So your neck veins will distend because they cannot enter, blood cannot enter the heart normally. So there will be backup of blood from the head and also from the upper extremities. And of course, less venous return will mean less cardiac output also. So that's why you have decreased cardiac output, blood pressure will drop. There's this pulse, paradoxical pulse, meaning your blood pressure is higher during exhalation, lower on inspiration, based on the illustration we just discussed. Okay, so at the peak of inspiration, the heart is squeezed, so therefore your blood pressure drops during inspiration. It gets better during exhalation. And the other symptoms are, I know this says decreased heart rate here. This will be later though, but initially as cardiac output drops, as you learned in chapter 11, initially the heart rate will increase, but after a few minutes, the heart rate starts to drop because now the cardiac output drops. Remember, the heart also needs blood. So if your blood pressure and your cardiac output drops, that means the heart muscles are also receiving less oxygen, less blood. When you listen to the heart sounds, because of all that fluid inside the pericardium around the heart, when you put your stethoscope there, can you hear the heart sounds clearly? When you got all that fluid or blood.
No, Professor, you can't hear it.
Right, so that's why the heart sounds will sound muffled or distant. So the test question on the NCLEX will use either distant heart sounds or muffled heart sounds. And of course, the blood pressure drops because cardiac output drops. So cardiac tamponade is an emergency, and you know the author already. This author, whenever it's an emergency, she puts it on a chart. So here is your chart, 35-9. It starts with the signs and symptoms. This is for pericarditis in general. So this is the pericardial friction rub. Now you have to distinguish though. Pericardial friction rub is not an emergency. This is an expected symptom of pericarditis. Okay, it's not life-threatening. This is caused again by the blister. Okay, the inflammation, the inflamed pericardium against which the heart is beating. That's what's causing the pain. So you give NSAIDs for that. And here, no anticoagulants or aspirin because of the danger of cardiac tamponade, which we know is not good. So these are now the signs that the patient has possibly the development of cardiac tamponade. So you have pulsus paradoxus or paradoxical blood pressure. Then you have the jugular vein distension, muffled heart sounds. Take note that here, the JVD here is not caused by heart failure. This is caused by the compression of the heart because of fluid around the pericardium. That's why, unlike the jugular vein distension you saw in heart failure, wherein the patient had crackles, right? Because that jugular vein distension was caused by heart failure. So in heart failure, you hear crackles in the lungs, not here in cardiac tamponade. The lungs are clear because the jugular vein distension was caused by compression of the heart by the fluid around the pericardium. And of course, the muffled heart sounds or distant heart sounds and the low blood pressure. So when you see these, it's only one thing we can do is call the doctor. doctor needs to do a emergency procedure. That's right here. So our intervention for this is called pericardiocentesis. As described here, he'll use a large needle, 16 to 18 gauge. It's long, it's 8 inches long. So he'll insert it into the pericardium right under your sternum. Of course, this is not done blindly, okay? So the doctor needs ultrasound guidance to see where the needle is. So under ultrasound, he'll insert the needle into the pericardium and then drain the fluid. And that should relieve all these symptoms right here of cardiac tamponade, and the cardiac output goes back to normal. However, if for whatever reason the cause of the fluid accumulation cannot be eliminated, meaning that this is likely to reoccur, a drain may be in place, left in place. So he'll put a catheter to constantly drain the fluid. And if, let's say, the cause is from cancer, because this can occur also in lymphoma, meaning this is likely to reoccur, and we can't leave a drain there forever because the drain is a foreign object. It is a source of infection. So what the doctor may opt to do is cut a window. So since we can't get rid of the cause, we'll just have to cut a hole in the pericardium, allowing the fluid to go somewhere else. Usually it's either in the pleural space or into the peritoneum, where it can't cause any cardiac tamponade. Any question?
Nope.
All right, so let's continue with rheumatic carditis. This is very quick, and then I'll leave you, I'll give you a break. All right, rheumatic carditis, this is a consequence of rheumatic fever. Another name is rheumatic endocarditis. It's similar to endocarditis in the sense that it causes valve damage. It also is caused by the same organism. It's also caused by Streptococcus. Usually the problem here is the patient got strep throat and was either not treated or was undertreated. Not treated meaning the patient just, I don't know what they do, maybe drown the sore throat with vodka maybe, or a lot of alcohol, and then they somehow, survive, but then they don't know that the organism already caused damage to the heart valve. So several months or years later, they'll have signs and symptoms of heart failure. And then at that time, it's already too late. The patient's already in heart failure because of the valve damage that resulted. It can also be under treatment. Let's say the patient did seek treatment, but then they did not finish the antibiotic. So it became useless, and then you know the rest of the story. So the most serious complication of rheumatic fever is really the valve damage that occurs. And then the patient develops heart failure. So that's the long story, keep it short. And then that's all rheumatic carditis is. So the patient got an infection, was either not treated or undertreated. They develop valve damage, then now have rheumatic carditis. When they have the acute episode though, just like any other infections, or rheumatic fever is again caused by strep throat. So we treat them with antibiotics. So oral penicillin doesn't have to be IV. This can be treated orally. So penicillin, or if allergic to penicillin, we'll do erythromycin. And that's it. And then the same thing, because now we have valve damage. So now we need to tell this patient that they need prophylactic antibiotics before any oral or dental procedure. Okay, so it's right here. questions on rheumatic carditis? That's it. Okay. Then finally, cardiomyopathy.
Question, actually, Professor. I believe last time you mentioned that if they have to take an antibiotic before the dental procedure, they might have to stay on it for
And
past
that
procedures,
is
right?
simply prophylactic.
Oh, it's only prophylactic. Okay.
But during the acute episode, when they're having the rheumatic fever, meaning it's still an active infection, hopefully we treat it soon enough that it doesn't lead to valve damage. But the same treatment, we will do penicillin or erythromycin.
Got it. Thank you.
All right.
Professor,
Yes, sir.
is there or does the patient have to do prophylactic antibiotics for dental for all of these?
Yes.
For endo and the other two, right? And
Yeah, any condition that leads to valve damage or valve replacement, yes, all of them require prophylactic antibiotics because they are all at risk now for endocarditis.
all right, so all these I have to have prophylactic. All right, thank you.
So that's what I meant by same story. All right, so we go around, no matter how you look at chapter 35, they always mention prophylactic antibiotics because all of these either lead to valve damage or the valve damage will put them at risk for endocarditis. Cardiomyopathy. I won't test this extensively because the root end result here is really still heart failure. These are the known causes. It's known to cause, actually after childbirth also, pregnancy may predispose you to cardiomyopathy. There has been cases wherein the patient develops cardiomyopathy from pregnancy. But most common causes are alcohol abuse, chemo, infection, and poor nutrition. Look at the types here. My drawings are weird. I don't know why they appear like this, but on your textbooks, it should look better. Look at the shape of the heart here. This is dilated, this is restricted. Either way you look at it, is this a normal heart? Can this function normally? Let's take a look at this one first. Look at the walls, so thin, so big. So that means the preload here will be extremely high, but then are the muscles strong enough to get rid or to pump all that increased fluid volume, blood volume?
No, so it just stays there.
Oh. Hell no, because now you have a lot of blood to pump, but then very weak and thin muscles here that it's impossible. So the patient pretty much is in heart failure here, major heart failure. So this will fall under maybe class 3 or maybe even class 4. Because there's no way this heart can function normally. So the patient here will require heart transplant. Until then, you maintain and treat them for heart failure. Same thing here. So you have restrictive here. So these large walls here, look at the septum, so large. This is also hypertrophied, but doesn't mean they're strong. Okay, so they have the thin walls here. So look at the size of the ventricles now. The ventricles are not big enough to have a normal ejection fraction. So same way, again, either restrictive or dilated cardiomyopathy, you have heart failure. Look at the signs and symptoms. Sound familiar? So they're the same as in charts 35-1 and 35-2. So the only thing you need to remember about cardiomyopathy is the patient is in heart failure and needs, this one's worse though than heart failure. At least with heart failure, you can manage it with the doables. You can take drugs, you can live a relatively normal life. Okay, as long as you stay with the treatment, comply with the diet and activity, you'll be fine. However, cardiomyopathy, if look at these, you can't do anything here. What activities can you do? There's no way this heart can provide oxygen demand from any activity. You know, let's say go out, enjoy life, walk go walking for so long, you won't make it that far. Okay, with
Okay.
hearts like
So
this.
they would just need a transplant, right? That's the
Yeah.
option.
Uh-huh.
Okay.
And you're saying it like, just a heart transplant.
No, I'm saying like that's
I'm
the only
kidding.
thing that would help them.
Yeah, so yeah, pretty much this patient, like I said, is either class 3 or most likely class 4 heart failure. And that's it. So go on a break and then we'll continue in chapter 36.
Okay.